It's a full house today. Understandably, because of our visiting guest. I'd like to first start by introducing the lectureship. This is the second annual Mark Miller lectureship in orthopedic sports medicine. Most of you know Dr. Miller, but those of you who don't, Dr. Miller, stand up. I'm going to make you stand up. So Dr. Miller was a dear mentor to me. He was on faculty here for 24 years, started in 2000 after training at Wolford Hall, med school at the Uniform Health Services, was at the Air Force Academy, and did his fellowship at the University of Pittsburgh, UPMC. So that's where our esteemed guest is from. But Dr. Miller has a storied career, truly one of the most, if not the most recognizable name in orthopedics. He he was a clinical expert in multi-leg knee injuries, in cartilage restoration, meniscus restoration. He's published 40 plus book chapters, 40 plus texts, hundreds of book chapters, over 275 publications, internationally known for his work in sports medicine. He's a tremendous educator, won the Revere Award for Education from the AOSSM. He was president of AOSSM in 2023, but most importantly, he was a dear friend and a mentor to so many of us in this room. He inspired us to pursue orthopedic surgery, inspired us to pursue sports medicine. He gave us opportunities through the Miller Orthopedic Review course, which is in its 30th year, which he started, and is the busiest and biggest orthopedic review course for orthopedic residents taking the board exam. So he retired as the Sam Cassell's Professor Emeritus in 2024, still involved with our department in education and mentoring. I am where I am, large part because of Mark taking a chance on me to have opportunities to contribute to research. And he's been a dear friend and mentor to me. And it's really a great honor to have this lectureship in his name. So thank you, Mark, for being here. Thank you for all you've done for everything in the department. And we are here because you built the foundation that we have stood on and grown as a result. I'm going to introduce Dr. Dieduk to introduce our speaker, and Dr. Dieduk, our Division Chief of Sports. Hey, Winston, there's a echo up here. Okay, got it. Okay.
Thank you, Bobby. Indeed, I'm honored to introduce Volker Musahl, our friend, colleague, giant in the field of sports medicine. It's, I think, especially fitting that he is the Miller visiting professor of sports medicine, as Mark did his sports medicine training at Pittsburgh and followed in the legacy of Freddie Fu, but Volker's really gone so far beyond that. Volker, you really started in the shadow of Freddie and on the shoulders of Freddie, but you've created your own legacy and a real leader in sports medicine now, internationally acclaimed, leading the world in terms of ACL research, osteotomy. He came yesterday ready to go, and we were in the osteotomy lab. You start with a chalk talk on the wall with principles and really innovative ways to think about osteotomies, and then off we went to the cadaver lab, rolling up the sleeves and going. It was really, really good. But he's got a long list of titles: professor of sports medicine, chief of sports medicine, fellowship director, even has a appointment in Sweden. You have to tell us about that one. I'm not aware of that one, but and also the head team physician at Pittsburgh Sports Medicine. So it's really an honor, and we're very grateful for you to come and share your time and your expertise. Thank you, Volker.
Thank you so much.
Thank you very much for the introduction, and thanks so much for inviting me to come to UVA and give the Mark Miller visiting professorship. It's a huge honor for me. I've known Dr. Miller for those 25 years I've been in Pittsburgh and always looked up to him, and it's really amazing. So thanks for everyone for coming. This talk's going to be on ACL, so those of you who are not interested in the ACL, you may feel like falling asleep, so there's coffee in the back. There are disclosures and conflicts and all this, but I try to be as clean as possible. So thank you again, and thanks to the chief residents for I suppose you proposed my name to Dr. Miller to be this lecturer, so thanks very much, very honored. I just summarized real quick what Dr. Chabra has said about Dr. Miller, so lots and lots of accomplishments. I published a few books myself, and after my 5th book, I felt lucky and put a tweet out and said, 5 books, oh, so exhausted. So Mark tweeted back and said, 35 more to go, buddy. So, you know, some championships and really, Mark has been an amazing educator. And of course, the AOSM George Rovere Award is the biggest educator award, and he deservingly got that in 2015. Now, this though is Mark's favorite picture. And look at Freddie too, how he's excited to have such a great fellow. So Mark told me once that he spent 1 year to do a 10-year fellowship in Pittsburgh because it was so busy. But many people followed in Mark's footsteps. So Annika Chabra was there, I think in 04 or 05, and then Steve Cohen and Jeff Baer and Key Miller and Steve Igby, and of course the mayor himself, our chairman in Pittsburgh, Michaelis Hogan. So Mark came to Pittsburgh because of Freddie, and Freddie was not just an orthopedic surgeon, he was on the list of the most influential Pittsburghers of the century when I arrived in 2000. So that list has a few names you may recognize: Andy Warhol, Carnegie, you know, Dennis Miller, Frick, Rachel Carson, etc., etc. So he's really somebody that everybody in Pittsburgh knows. He built this, the big sports medicine center, and in 2018, his name was put on the building. And there was a huge crowd there, former football players, patients, etc., to be there with him for this big honor. I'm going to show you a couple more pictures. And once the iPad came out, Freddie got all excited about photography. And Mark, Bobby, probably you all remember, like every week you would get an email with pictures that he took. So he took this picture, for example, which is amazing. So, and every picture had a sort of a legend. This one was silver lining, you know, all these beautiful pictures. But at the time, he didn't really know that there's something called BCC. So he CC'd everyone in there, all of the AOSM leadership, all of Issaquah's, all of the chairmen that he knew, all of the Pitt alumni, probably 1,000, some 100 people. And invariably, somebody always emailed back and said, "That's a beautiful picture." And then 1,500 people get the reply back. And all of these replies kind of stunk, except this one. So this is, he's flying home from China, I guess over Siberia. He takes this picture of a frozen Siberian village. And Mark Miller texts back to the, or emails back to the whole group, "Hey, Freddie, is that the place you always threatened to send me to when I fucked up?" That was an all-time classic. So, all right, so now we get into ACL. So if you allow me, I start a little bit with the history of ACL. Now, this is not Air Force, but Army, Navy. This is how the ACL study group started. And it's John Fagan there in the middle picture, and John Bergfeld, who talked a little bit about the different ways how to treat the ACL back in the 70s. And Fagan told Bergfeld, "Well, I do this repair, but it doesn't seem to work." And at the same time, in Lyon and in Toronto, very famous, and you know these names, they created the lateral extra-articular tenodesis, which is just a reinforcement of the IT band over the lateral capsule, but not really worrying about the ACL at all. So the knee was very imbalanced and didn't quite work. Also at the same time, this is Ron Losey. Very few of you will know that name, but he came up with the pivot shift. So he's a surgeon in Montana, but he, you know, drove around the neighborhoods like a primary care doc and treated the whole community over there in Bozeman. And he described the pivot shift at the time. So it's a nice picture of these two giants there together. One more piece of history. You all think of the miracle probably with Lake Placid and the hockey game in 1980. So in Germany, this is our miracle. In 1954, Germany was in ashes and not supposed to be a good team, but they won the World Cup. And I put this picture there because in Bern is where Rolly Jakob worked. And he's also a pioneer. He was the second Issaquah's president. And, you know, 50 years ago now created this grading system for the pivot shift, which is how you measure ACL insufficiency. And we still use that grading today, 50 years later. Nobody really evaluated that or validated that grading system. And we used the Panther meeting to do that a few years back. So the Panther meeting is something Freddie established in the 80s when there weren't all that many sports meetings or, in general conferences. Now you have, one every week basically, but it was a very unique thing. And then you're in Freddie's OR, and Mark remembers this, there are at least 20 other people standing there and watching, and Adam Scheimer remembers this too. And you can never really see what's going on. So out of that, stressful situation, we kind of developed this test where we just put markers on the knee, watched them move, and then measured, how the knee, how much of the pivot shift occurs. And we used the Panther meeting in 2011. You see 12, world experts there, and had them do their pivot shift, measured it in all different ways, electromagnetic tracking, computer navigation, what have you, and came up with what we call the standardized pivot shift, if you will, a summary of these 12 different ways to do it. We developed an iPad app, and this app spits out a curve, quite instantaneously now, and gives you basically translation over time. Very much this works, and it's available for free, so there's no cost with it. We then were lucky to receive some funding from the Isakos Foundation, and in 2012 did this big multi-center trial with multiple centers, and David, this is how eventually I got into Sahlgrenska University. I have trained many of their PhD students at this point, but we came up with a number of, quite impactful publications, and maybe the one people might know the most is, what does it take to get a high-grade pivot shift? So these are all the things that, if they're injured, they will lead to a high-grade pivot shift. And if you look at this X-ray, those of you that do sports medicine will see a quite normal looking X-ray and MRI, and this will be a knee that doesn't shift very much. And when we set out with this pivot shift technology, we wanted to understand, how can you predict that somebody will have a big pivot shift? And so if you look at this second X-ray here with a high slope, this will be a very high pivot shift. Those are things that we kind of established. And if you look at that MRI, it just looks a little bit different than the one on the left. The right MRI basically shows a large offset of the femur. It shows a very small lateral tibia with a really high dome. And the meniscus distance that you can measure as a surrogate there is very small compared to the MRI on the left. And so Sahil Dadu, who's second-year resident with me, kind of came up with this ratio, and you can predict there's a high-grade pivot shift, and therefore you can then go ahead and maybe tailor your surgery to it. Now, I'm going to show you a couple of slides that are all from Freddie from back in the day. So Mark will remember these slides. Some of them are really cool, but he's, of course, still today the most published ACL surgeon worldwide. I don't know that anyone's ever going to catch him. And this is a picture of him in the 90s. This is probably how you remember him, Mark. So these are some of the slides. He basically came up with the idea that the ACL ought to be reconstructed anatomically. And at the time, it was the double bundle, which a few people also adopted. But the main thing was that you should look at these insertion sites. You should replicate them when you do your ACL surgery. He went all the way over to Cleveland and met Dr. Owen Lovejoy, who discovered Lucy's bones, the oldest human bones, 3 million years old, and he got them to CT scan. I'm not sure how you do that, to go to a museum, steal a bone, CT scan it, put it back, and then showed that the modern and the Lucy basically looked the same. I remember it very vividly. He was so excited about it. He had a fellow that every time at the Pittsburgh Zoo an animal went under anesthesia for whatever healthcare, he would send the fellow in there and measure the rotation. Tigers, polar bears. Remember that, Mark? I mean, unbelievable. And there are hundreds of these videos. And then you study the different bone morphologies and find out that there's huge differences of those species that rotate a lot versus don't rotate. All very exciting stuff. And the biology is really what excited Freddie the most. And, when the surgery that Mark and Freddie did in the 90s probably took 10 minutes to do the ACL, he actually slowed down with his age and started studying, like this video you see there, and, going back and forth, discovered the septum on that second picture there between the bundles, and then CD34 plus, multipotent stem cells within the ACL, and these fetus specimens, which, showed the PL bundle that many people argued doesn't exist. So that was very exciting. Now, all that being said, I just put this one slide in here about ACL repair. And this is actually very interesting. So I had a pretty long conversation with ChatGPT over the weekend, and I told ChatGPT, give me a slide and make a table for me. So I didn't touch this table at all, but I kind of know the literature a little bit. So it came out actually quite well. All I did to this table is I highlighted these three things. And I think what's important to know about the repair, even though there are stem cells and different bundles and beautiful biology, in young people, the repair doesn't seem to work all that well. The failure rate is still very high. And then, of course, there's the big bear trial, and where you have, in short term at least, good comparable results, but those are in patients over 30. So, and also one thing I always wonder when you look at these graphs, right? These graphs don't really show ACL reconstruction or anything resembling it, and the anatomy is in a quite different spot. So that's always, it makes me a little bit nervous. AI, by the way, is the future. These digital twins going to be all around us. So I think everyone should probably get used to working with AI. A few words on bony morphology. As David mentioned, we were in the lab yesterday. I think the bone is where the money is. This is statistical shape modeling. You probably recognize the name. It wasn't Troy, it was his nephew. It was a PhD student of us. But he did this statistical shape modeling and found that the femur has a bigger offset. The lateral tibia is smaller, there's greater valgus in those people that have ACL deficiency. And we also looked at what happens with ACL graft failure. And Jonathan Hughes, my partner, did this study where if you see a patient with a small notch versus large notch, you could think that it might be more forgiving to put an ACL in a large notch. And it is so that there's less failure in those cases. All patients that have ACL tears have on average a higher slope. And that even goes to football players. As a study we did on 100 players. And on MRI, we measured 4 versus 7 of a slope. So that's a very important finding, and I'm going to get back to the slope a little bit later. Nick Absalov was a fellow last year. We wrote a couple of nice studies together, and this is just summarizing in the yellow journal all the different extrinsic and intrinsic risk factors for your ACL. And most of them are not modifiable. Another good question is, does size matter, right? Everybody thinks size matters, and obviously there are huge differences in the different athletes. And a very nice study that we did a few years back shows how the different grafts enable you to replicate the size of every individual ACL. And there are big differences. People have 10 millimeter wide ACLs versus 20 millimeters. And the quadriceps tendon, which is pictured on the lower bell curve there, enables you to do that kind of the best. You can take a very thin strip, but if you wish, you can also take a very large strip of quad tendon, and you can even take 2 bundles, which is what Freddie did in a randomized study with a double versus single bundle. So I'm going to talk a little bit about ACL tunnel placement and quad tendon. And this study was very eye-opening. You have to imagine we're at the ACL study group meeting, all world experts, 2014, I believe it was, in Cape Town, very nice place. And James Robinson and Charlie Brown gave us an X-ray and a pen and said, put your marker where you think the ACL goes. Then they took us into a lab room and gave us a Stedman awl. And there was a specimen, and then they said, okay, now, put the awl where you thought, on the X-ray that point is. And you can see this green and red. So, I mean, some of them were like amazingly different, and what your perception is and where you actually put it. And this is what this paper points out. And out of that, I started studying a little bit in Pittsburgh, where we have a huge registry of, academic and community-based surgeons. We have more than 50 ACL surgeons that work just in Pittsburgh. And imagine the whole Swedish ACL registry only has 75 surgeons. So that's the whole country. So Pittsburgh has a really high number there. So this X-ray shows on the left an intact ACL at a few years out, and on the right, somebody that obviously had 2 ACL surgeries. And the green dot is where the tunnel should be. So all the intact ones that we measured were quite, within the right spot. but all the failed ones were more than 200% outside. Obviously, this doesn't mean that every misplaced tunnel fails, but it means the opposite, so that when there's failure, usually you see this. And why is that? It's very difficult, but surgeon experience has something to do with it. Also, in the old days, I remember with Freddie in the OR, and Adam and I were chief residents, ACLs, again, took 15 minutes and there was no meniscus surgery or anything. But the question really is, does an isolated ACL exist? And if you look at some newer publications, there's one from Ashish Bedi recently in JBJS, maybe a fourth at best isolated. So these days, we're looking quite closely into the meniscus and into the other structures that probably need to be fixed at the same time. And leveraging this connection with Sweden and the Swedish registry, so you can see the powers and the numbers, almost 30,000 patients. If you look at patients that have meniscus injury at the time of revision or cartilage, they usually had a meniscectomy in the first case. So the message is don't do meniscectomies. Another very interesting study from that same Swedish connection is by Janina Kari, who is actually now one of our residents in Pittsburgh. And you know those people that have poor outcome, they have cartilage injuries and higher pre-op Q scores, whereas older people, male sex and hamstrings in that particular registry have a better outcome. So overall, the message is save that meniscus. Graft trends. You're probably used to patella tendon here at UVA, I would think. And in Pittsburgh too, we do patella tendon and hamstring, quadriceps. But the worldwide trends are hamstring tendons. 80% in the world is using hamstrings, and quadriceps is gaining a little bit popularity. We did the same survey for the Herodicus Society, and it's more reflective of what you see here. So patella tendon is about 60% of the membership. The other three grafts kind of evenly distributed. So talk a little bit about quadriceps tendon. We kind of fell in love with that tendon, I don't know, about 15 years ago, and Freddie was in search of a suitable graft for double bundle. And if you randomize somebody into single versus double, you got to have the same graft size, which is hard to do with hamstrings, impossible to do with patella tendon. And allograft did for a while, but you all know allograft is not a good idea in young patients. So the quad tendon kind of came around. We did a lot of publications, but Christian Fink, who's pictured there next to me, is the one that popularized it over in Europe. So if you compare quad tendon with hamstring tendon, you will see there's actually less pivot shift, and obviously you will not affect flexion power at all in your rehab, obviously, and hamstrings are the agonists to the ACL. So this is very helpful. You compare to patella tendon, which is considered the gold standard by many. It has comparable outcomes and comparable failure rates. When we talk about revision, it's become probably the #1 graft in revision. And so we looked at what happens to the extensor mechanism if you hit it twice, quad and patella tendon both, and didn't make a difference with quad recovery. We did a lot of ultrasound studies also and found out that it doesn't really matter where you take the graft, the tendon thickness isn't affected by it very much. Initially, we harvested the quadriceps tendon as seen here and taken off from the patella first, but recently switched that and you get a much longer graft if you harvest the tendon on the proximal side first. It's just a couple of seconds here of a video, but you can use cutting tools, etc. And then when you harvest the tendon by separating the rectus from the intermedius layer, and then severing the tendon first at the myotendinous junction area, and then going retrogradely down to the patella, you get an 85 millimeter graft, which I believe is quite important so that there's enough tissue in the tibial tunnel. So here are my indications for quad tendons. We use it in soccer players, sprinters, they have high flexion, or martial arts that, use their flexion power quite a bit, or laborers that kneel a lot, where patella tendon might not be the best. And we do it with bone block in revision, ACL, and PCL. Is quad for everyone? I don't think so. And this is a study that kind of points to that. And unfortunately, female sex, increased age, and large quadriceps graft leads to a prolonged quadriceps recovery. So yes, that is still a question out there. And how do we mitigate this? And I think this is one of the most interesting studies I was only peripherally involved in. This is a study on 10 only female athletes, so there's no male comparison. But 3 years after quad ACL reconstruction, they still had changes in their corticomotor map with respect to the biceps. It was much over firing in the ACL group. So there are lots of changes that we don't completely understand yet and might be able to intervene in the future. So here's a case where I like to use quad, soccer player, ACL tear, regular sized ACL, lateral meniscus tear. Look at the quad, how it recovers. This is an email I got from his trainer 8 weeks later. So it works quite well. Now, inspired by Freddie and his picture taking, I took this picture, and those of you who know Hilton Head know exactly where this picture is taking. And I'm switching gears now to the anterolateral side, which is where, these thunderstorms started occurring in 2013. It was very interesting stuff. So many of you might remember in 2013, a new human body part was discovered. Anyone remember? Mark remembers, David remembers. So a new human body part. So we all kind of set out to try to find this so-called ALL. So this is our sort of first attempt at finding this. Shine a light from the inside. There was really nothing there other than the IT band. Then you can do a haircut and find the ALL. So we published that a couple of years later with sort of a picture, survey where you go from the skin down to the capsule, and you find this thick interosseous layer and like a deep IT band layer. But really, there wasn't much as of the actual ALL. And we did a couple of big biomechanical studies. I'm just putting 3 or 4 here, not to bore you too much with it, but this is a robotic testing of a whole knee. And then we did sequential cutting. You cut the ACL, and you can obviously see it picks up most of the forced knee extension, which is where it also injures. Then we cut the anterolateral capsule, and there is load sharing and higher flexion angles, also with the LCL. But then when you narrow it down to just the ALL, it was quite negligible. And then in the same type of testing setup, we now put a strain marker map on the lateral side of the knee. And that rainbow map basically shows where most of the strains are, with the brighter colors having the heavier strains. And the red arrow on the right picture shows where the proposed ALL is. We couldn't really replicate that at all. There were no loading conditions that could replicate this, and therefore we called it a sheet of fibrous tissue. That got me a lot of heat and a lot of angry phone calls, as you can imagine. However, this is science, hypothesis-driven science. We also couldn't find any ligament or tendon precursor cells within specimens, lack of scleraxis, tenomodulin, and so it really behaves more like a capsule. And then, as I mentioned earlier, Freddie really, he went deep with all this research. So there's a fetal specimen he got from Children's Hospital, I think 30 or 40 of those. And you can see nothing in the area where an ALL is supposed to be. And if you think about how the human, knee develops, the fibula pulls away from the joint, so it pulls the tissue down, which is called the LCL. And on the tibia, there is no ossification center that would do anything similar to that. There's a different publication, with maybe not quite as an elegant dissection, which kind of shows the opposite. So at that time, and this is another publication where, a lot of angry phone calls were made afterwards. Freddie and I published an editorial called ALL Fact or Fiction. Didn't say it's fiction, just kind of pointed out, in 10 points, these are our findings in adult specimens, fetal specimens, of course, animal too. He studied, lemurs and others. There's some specimens or species had 2 LCLs, but nobody had an ALL. So just summarized all of these findings and said, think about it a little bit before you go there. And people got really angry. So other publications kind of also a little bit coin toss. If you have 1,000 publications, 500 say yay, 500 say nay. So in 2018, Charlie Brown and Al Getgood summoned all of the ALL masterminds of the world into London, and we sat down for what we thought will be an interesting consensus meeting. Now, it was interesting, to say the least, but it was more like this. So these are all the names that were involved. It was a very large group. It was a room like this. Everybody had a microphone in front of them. You could only speak one microphone at a time. And so the first statement, we set out to put 15 statements out. And the first statement was, does it exist, yes or no? 80% said yes, so move on. Next statement, what is the ALL? Now people started screaming, and it's, goes through the separate layers, and it's deep, it's superficial. And I mentioned it's in the capsule, and people shouted at me and said, you already said it doesn't exist. You're not allowed to talk anymore. I'm like, okay. Then Charlie Brown called for that timeout and said, let's go through the 3 layers, that the residents learn on the lateral side. All agree it's not layer 1, the IT band. Yes, agree. Not layer 2, the LCL. Yes, agree. So again, I put my microphone on, it's the capsule. So we adopted, that's a capsular thinking, whether people believe it or not, and had basically 5 statements that we came up with. And that's a publication. It's many, many citations to it. But we couldn't agree on a lot. So then we just created a randomized controlled trial in Pittsburgh, very small trial, only 20 patients, but with probably the gold standard of clinical outcome, which is having people run on a treadmill after that surgery, getting a 3D CT scan by measuring orthogonal fluoroscopic videos. So we have basically kinematics of a downhill run. And 6 months after this adding of lateral surgery that I didn't think will do anything, and I was actually afraid setting up this study that people point at me and say, you don't want to show a difference anyway because you don't believe it. We see this. We see a knee that is 4 millimeter more posteriorly translated, tight like crazy. I was really worried that we would, quote unquote, over constrain these patients. And I'm just gonna, if you allow me, the Matrix movie. I hope many of you do, right? And in that movie, this little Buddhist kid explains to Neo the spoon, the essence of life, right? How you feed yourself. So we were thinking, is this thing the spoon? But then 12 months later, you see it's basically even out, and it kind of stretched out. So in essence, there's no constraint. Okay, so we do give some credit, of course, to the publications that were done mainly in Lyon, where adding a lateral procedure, namely an ALL reconstruction to an ACL, effectively and statistically significantly reduces failure rate after ACL reconstruction. So there's certainly something there. And in preparation for a talk I gave a few months ago in France, where I figured I don't want to show them all this data again. They're just going to hate it. I just had another interesting conversation with ChatGPT. And that was my first time dabbling with ChatGPT. This maybe 2 years ago. And I just asked it, what is the ALL? So it tells me it goes from the femur to the tibia, blah, blah. So I decided, let's just ask it the real question. Does the ALL exist? I was convinced it would say it exists. But, nobody's perfect. So it got so wild in the room that Sonri Cote told me that the ChatGPT is sponsored by Smith and Nephew. Anyway, it was hilarious. Now, back to science. The Stability 1 trial is the biggest publication over the last 5 years in ACL. Now, per year, you guys know how many ACL papers are in the literature every year, new? About 2,000. It's ridiculous, right? But this is by far the most cited study over the last 5 years. And it shows that if you add an LET to a hamstring ACL, and only hamstring, you reduce the failure rate from 11 to 4%. So this is certainly very interesting. And last year, we got actually some nice phone calls from Bertrand Sanri-Cote, Camilo Helito, and others, and we set up for a Consensus 2.0 meeting in Naples. And it was much nicer than the one in London. And now we had data, right? We had the stability study, we had many outcome studies. and it's very clear now. So we had multiple statements that we adopted. And most importantly, if you do a hamstring ACL on a young athlete with a big instability, you better add an LET. And I believe that. I just don't do hamstring ACLs. Okay, you can laugh. That's okay. So the next question that we had is, how do you go from this hamstring ACL and LET works to applying it to the gold standard, patella tendon? So we just finished the Stability 2 trial in May. So in 2 years, you will see the data from it. It's a randomized controlled trial, the exact same inclusion criteria as Stability 1. So I have absolutely no data just yet because we have to wait until the 2-year outcome is there. And if Stability 2 shows the same to be true for patella and quad, then obviously I will change and apologize. It won't. Okay. One more topic, and maybe this is where the actual spoon is. It's the slope of the tibia. So we did the lab last night, and I showed you all the data already. And if the slope of the tibia is high, your ACL will have a high chance of failure. That is a fact. We didn't come up with this. The veterinarians did. Probably people have golden retrievers here in the room. This is the X-ray of your golden retriever, 40-degree slope, which is fine. It's designed like this. But if the ACL tears within 6 weeks, they get osteoarthritis. 6 weeks. So they don't ever get an ACL reconstruction. They get this osteotomy. So when I first presented a sloped osteotomy case at the W Society, 2016, I forget at which location it was, they booed me off the stage. Musahl, you're doing animal surgery, you do dog surgery. What are you doing? But if you're willing to take some risks, obviously everybody is talking about the slope right now. I mean, there are publications everywhere, and we're learning more about it. This is what happens. The slope is high. There's 75% increase here in anterior tibial translation. If that occurs in a slope reducing osteotomy, will then reduce the force and reduce the failure rate and shift the tibia back under the femur where it belongs. There are different ways how to do these osteotomies. We did 1 and 3 yesterday in the lab. Below the tubercle is where currently the trend is going. It's technically much easier to do. However, this is a nice little study we just finished. When you go below the tubercle, you have to have a different calculation of what your wedge height is, and you will most likely get a little bit of a cortical mismatch that might be slightly painful to the patient. I'm going to skip this video since we did this yesterday, and I can share this with everyone if you're interested. It's actually a very nice educational video. So the studies that are out there on slope osteotomy, you can see these numbers: 5 patients, 9 patients, not very much until Andreas Weiler published on 70 patients, but the series are quite small. But they all have the same message. Number one, the slope gets effectively reduced. Most people over-reduce the slope, to about 5 degrees. Number 2, the anterior translation effectively and massively decreases. But then if we look at our own data, this is what GetGood and I did together. You can see IKDC 52. So these are all patients that had at least 2 failures. So they're not like high-fiving you in the sense of, hey, I'm loving, playing American football again. But they now have a stable knee, and very few of them fail again. So that's success. We again employed our biplane fluoroscopy technique to study these patients. This is not published data yet on just 5 patients, but I wanted to put this in there for Mark to see and for you all to see. But this is a current study that's ongoing. You can see in red there before and after ACL reconstruction, massive shifts in translation, very effectively and massively reduce the translation, which is what we're trying to achieve, because all of these patients, like the X-ray on the left there, have a fixed anterior tibia translation by having a high slope. So this is a nice way to reduce this. When is the slope significant? That's the current hot question. Can we just do an LET and don't have to bother about the slope? Well, if the slope is greater than 9, you have about a 3 times greater odds of graft rupture. So you have to think about that. At the AOSSM meeting last year, you know, now that I said all this to you, you would say, well, this is a slope guy, right? Not an antilateral guy. Anyway, they had me debate, you know, pro LET, you know, against Robin, who said pro slope. So of course I won, but I still believe the slope is more effective. I'm going to show you one case and then I'm going to wrap up. So this is a typical case of somebody who had 2 failed ACLs. You see a little bit of flexion contracture, and they have a very, very high slope. So you can measure here an 18-degree slope. You also see that funny metaphyseal, you know, scar there. So upon further asking, yes, there was a fracture as a 15-year-old that was just put in a cast, probably at Children's Hospital in Pittsburgh. And you can see the long tibia always overestimates the amount of slope. So the one picture in the middle is what we use to measure the slope. And then you can see on this 3D CT scan, massive depression of that lateral tibia and the tunnel from previous surgery nowhere near where the anatomy should be. Just a quick EUA video, you can see probably roughly a 10-degree flexion contraction. The guy actually didn't even realize because he lived like this since age 15. And although there's a big flexion contraction on anterior translation, still has a Lachman test and a very, very, very large pivot shift test. Bam, ouch. Okay, and so here we did a infratubical osteotomy. This was my first one. I was scared with all that smoke coming up. Like, this is clearly going to be a non-union. It didn't. It healed very well. You can see the picture on the upper left. There was no notch. It was completely overgrown with osteophyte. Once we, you know, hammered that away, you can have a native ACL there, and then did the slope reduction, and he enjoyed this very much. So in summary, here are my tips, you know, for a successful ACL reconstruction. Yes, many of those tips are stolen from Freddie over 25 years. I think the ACL should be anatomic. You know, we do preserve the stump because we love the biology. We individualize, so hamstring, patella tendon, quad, they all have their role. The pivot shift can predict, you know, your high-grade instability, and the MRI can too. Location, you know, you gotta go in the right spot. People don't want to talk about it. Meniscus, don't cut it out. You know, anterolateral, the LET use is definitely increasing, and kudos to the LET mafia for putting this on the map for us. Slope is a modifiable risk factor. There aren't many, you know. You want to change your shoes and call for the weather to be better. It's all not happening. The slope is the one thing we can change. I didn't talk about the antemedial side. There's a lot going on that side too. AI has potential. I think we all need to, who of you has used AI before? Most, yeah. Half of the room only, okay. You should get on with it. There's a lot of interesting stuff. This is only 2 years old, but completely outdated. We asked ChatGPT 20 important ACL questions and only 2/3 it got right. This has changed now, just a year later, but a publication that gets quoted all the time, interesting. We keep innovating. Annie Halia is a professor at CMU. She's absolutely brilliant. She got a huge NIH grant, and after she did all the work getting the grant, then she came to us and said, hey, can you do 90 ACLs for us real quick? I'm like, sure. And so she's putting all these wearable sensors on people and let them run on the treadmill and getting MRI, trying to figure out PTOA. This is Freddie's last Panther meeting, 2019. Those were some of the final thoughts there on how to, you know, return people to sports, you know, criteria-based, not time-based, and of course, psychological readiness. And I talk about in my second talk a little bit more. We were able to create a huge network through the STAR trial and then stability. And of course, thanks to UVA Orthopedics for being part of all this. I think, again, AI will help us in the future to kind of figure out how to titrate these surgeries and make them perfect for each patient. This is Freddie's message. The ACL is dynamic. The stump should be preserved. The graft is anatomic, individual, and then put the patient first. You know, he would love his athlete patients just as much as every other patient and would know every patient's name and their family, the kids. It was unbelievable, the number of names that he would know, but that's powerful. So try to remember people. I made this slide. This is my second to last slide. I made this slide for Freddie in 2000, trying to predict the future, which is now the past. So you can see some of it came true. We use robots, right? Do we use gene transfer and all these stem cells? We're still not really. So anyway, I made the slide for you trying to figure out what's going to happen in 2040. Maybe I'm wrong again, but I think we use virtual reality, AI, as I said. I think that we somehow 3D print a patient's ACL and then put that in perfectly. So with that, thank you again so much for inviting me to give the Mark Miller Visiting Professor lecture. I'm very honored and happy to take questions.
That was awesome. I think, I'm sure we have some questions.
Nobody slept. That's amazing. You guys are, wow.
That was a great,
Really powerful coffee.
That's good coffee. It's orange juice.
So, great summary. I really enjoyed it. Jean-Marie Cote says that the ALL reconstruction and the LET have similar results. What do you think about that?
I can tell you that when we were at this consensus meeting in Naples, the ALL reconstruction is kind of falling by the wayside. People that, like him, who said this is the way to go, stopped using it in favor of LET. Now, LET is much more simple because you don't have to use a graft. However, you rob a little bit Peter to pay Paul in the sense that you have to be careful with the Kaplan fibers in the back. So I don't know that these two procedures are the same. I really don't know what that procedure is doing. The study that I showed where it stretches out and the spoon bends, I think that to be true. I think that, in the first couple of months, the LET is very helpful and maybe helps, somehow, has a little more pain, maybe slower rehab, and so it protects the ACL, but then it stretches out. And I don't really know what it's doing. I think our research fellows, many of them sit back there, will figure this out. So, not sure. I agree that this is the same.
Stretches out, or you wonder if it heals directly there to the bone. That's the other
Yeah.
question I've always had. It's just tethered by the suspensory suture, and then that just, kind of gives up.
Right.
Once you're done, another question to be answered.
Yes.
Yeah.
So you say that the modifiable risk factor is the bony morphology, right? And so, the case example you showed was a multiple revision. A lot of the data on slope correction, multiple revision, are in the revision setting. Do you have a current indication for correcting the slope in a primary ACL patient? Do you do it? And when?
I haven't done it, but here's my indication, okay? So it's like this. The patient comes in and they already have an ACL on the other knee, and that's already failed on the other knee. And now the index knee comes in and the slope is 18, 20, like crazy. I haven't seen that patient. I hear those exist. In the Arabic world, I said that yesterday in the lab, in China, people kneel a lot from childhood on. And so they have higher slopes to begin with. So I haven't seen this, but that will be my indication to maybe do it in primary.
If you're seeing a primary knee in an athlete and their slopes
11, and I hate it. And I tell them, your slope is 11. And they say, huh? My what? And I'm like, yeah, I don't like it. Okay. So if you tell the patient too much that you don't like it, then they say, okay, then I go to Mark Miller and he's going to do it. Right. So you want to keep the patient with you or you want to let them go away. So I hate it when I see that slope, but I don't act on it. I may then pull my trigger on the LET more since stability one showed that. But again, I use quad tendon primarily and patella tendon. And I don't know what the LET does when you harvest quad, and then you have another incision right there on the quad as well. Stability 2 will show that. I don't know yet.
The follow-on question to that, thank you for your lecture, by the way. I'm Dave Weiss, one of the orthopedic trauma surgeons here. So I look at slope more of a, like, oh, it's broken, we need to fix it.
Yes.
But in that vein, if you had a patient, do you think excess slope makes it a higher risk to have an ACL? So in other words, if you have a patient who you're operating on one side and their other side does have a bad slope, would there ever be a consideration for a prophylactic slope correction to prevent an ACL, thinking that if you can get bony healing, you'll probably have a fairly normal, on an elective basis, you'll maybe prevent an ACL reconstruction with its subsequent you know,
See,
rehab
I-
and maybe limitations in function?
I tell all my residents, trauma surgeons love sports medicine. So I love that question. And I've been asked this question before. And of course, you might think, okay, let's do a fascial, let's do a fasciadesis and just watch over time and have the slope reduce. I don't know. I haven't seen reports on that. It's a logical next step. Again, it would have to be somebody who has a massively high slope. There's one publication from Norway, from Lars Engebretsen, who's a very, well-known person in the Olympic Committee, etc. And they followed young pediatric patients with ACL deficiency that they treated non-op over 10 years, and the slope did change. It did increase. So it begs the question, should you do some stapling?
You showed a really interesting slide where even amongst kind of world experts, their femoral tunnel may have been off axis from where they thought or kind of planned.
Yeah.
When you're doing an ACL reconstruction, like what are your steps, or do you have recommendations for how you kind of accurately and reproducibly kind of place your femoral tunnel?
So Chris Hana would actually take a fluoro shot on every ACL he did. And it was a teaching tool, right? I mean, after you do it so many hundred times, you kind of know where it goes. But he would put the Stedman on and then take a perfect lateral C-arm shot. Then you know. I don't do that, but I've done that many, many times in the lab. So I think I know where it goes. And when we did this study in Cape Town, in fact, we did this at a meeting. Do you guys know of the Pune meeting in India that Sachin Tapasvi runs and Charlie Brown? It's a huge meeting, 1,500 people in the audience. Pune is like the tech capital of India. They have like this huge parabolic screen there. They took 6 surgeons, eight of us, down to the OR and did the same test with us. Gave us a marker, an X-ray, and then there was a live patient. And then in the afternoon session, they put all 8 of us on the screen and said, this is where Musahl thought he would go, and this is where he went. And when those pictures were up, I'm like, oh my God, please don't let me be that guy over there. And, I'm within roughly where I want to go, but you can only do that if you check this on fluoro. You probably go to the lab. Let's go to the lab. We were last night and do it a few times, and then you know. But it's shocking how some people don't. Yeah.
When I was in practice, I actually did x-rays because we were studying tibial tunnels, and I decided to go ahead and do the femoral tunnel and retrograde the pin back.
Yeah.
And that way you could look at both of them.
Yes.
And so when we did that, looking at tibial tunnels to study that, we actually realized that about 10% of the time we were completely off in the femoral tunnel,
Yes.
even though we were experienced and been doing
Yes.
this for hundreds and hundreds of
Yes.
cases. So
Yes.
I think it's still a good idea
Yeah.
to do a lateral fluoro. Just by retrograding that pin back and take
Yeah.
a look.
Yeah. And if you see me do an ACL, you might be a little bit shocked how much tissue I remove from the femur to see what I want to see. Because in 10%, the lateral wall, kind of curves over to the lateral side. You're like, how do I even see it? So it's tricky, but AI will help you with that too. Soon, it's coming. I've seen it at the meetings, so it'll be in your OR before you know it.
One more question here. Someone else.
No, no.
Okay. So you mentioned AI, I mentioned several times, and I think that we all think, that's a lot of discussion about AI. AI is this, AI is that. Where do you specifically, I thought your decision tree was good. This, more personalized medicine. You can use AI to help you say, okay, or come up with an algorithm. Maybe using AI to come up with an algorithm to say, this patient, this slope, whatever the factors that you think are important to put into it, maybe for a more personalized graph. But where else do you see it coming? I mean, do you think it's like computer navigation is already here? That's not really AI, that's just computer navigation. Maybe AI makes it a little fancier, a little fuzzier. Where do you specifically see AI as helping in these types?
Massive data, and obviously radiology.
And the reason I'm asking is because it gets it wrong sometimes.
Yeah.
And
Yeah.
like you showed that first slide and you say, well, it's gotten better. The question that becomes though sometimes, like I asked this question, the Academy had a thing on this a couple of years ago about using AI. And I asked the question, I said, how do we know if it's hallucinating or not? Because that's, a known problem. They said, oh yeah, well, ask it a question about something you know the answer to.
Yes.
And I said, okay, that's fine, except that I want to ask it questions I don't know the answer to it. That's why I'm asking the question. If I know the answer, why do I'm not going to ask AI, I don't care.
Yes.
But how do we know then? Because it still comes up with some fairly high level hallucinations.
For sure. Are there radiologists in the room? Nobody. So Hollis Potter is the chief of MSK radiology at HSS. And she just takes the bull by the horns because that's how she is. So she is working on all these algorithms. And at first, you just have to sit there and you ask these questions that you know the answer to, and you go further and further out, and you have to accept some of these failures. But in radiology, reading is one way to have a failure. It's okay. In a surgery, you can't really have a failure, of course. But in radiology is where I see this for sure.
But that's pattern recognition.
Of
I mean,
course.
and sure,
And then
computers are good at
massive
pattern
data.
recognition and yes, that's fine. But I'm more asking, how do we see it in our world? I totally see it in pathology, looking at cells. I totally see it in radiology. I'm more wondering where it works in our world, where we have to make decisions, which I think it can be helpful as a decision tree. I think it can be helpful for patient education. You showed a good slide about, hey, the patient has all these questions. Maybe you don't have an hour to sit down with every patient and go over all their questions, but the AI can do it very well for us. But where do you see it in the world of surgery itself? Like the surgical procedure, I guess.
So in arthroscopy, in total hip placement, for example, you get your glasses on and it will tell you where the map goes. It will tell you where the cup goes in the femur, in the acetabulum. It will tell you where the tunnels go on the ACL.
Isn't that just navigation though?
Right. But the problem is that every time you do it, just like, so the Tesla car is not a great car, but what's great about it is that every data point ever of anyone driving ever in that car has been collected. So they have this massive database, right? So eventually, and in Pittsburgh, they actually trialed driverless Ubers, right? Somebody died. I mean, that's obviously horrendous and unacceptable. But unfortunately, this is how AI is going to get smarter and smarter. So you will have, if you rely on it, you'll have a wrong tunnel at some point, and then learn. And every year it's going to get more and more sophisticated.
Need to go to the next talk.
Yeah. And eventually we sit in Hilton Head at the beach and just do some joysticking. Yes.
The AI, that's for sure.
That was great. So, I mean, you're clearly a pioneer in the world of ACL. I want to recognize the rest of the audience. Probably a lot of people don't know is Terry Whipple.
Yeah.
But Terry is absolutely a pioneer in terms of upper extremity